Everybody. Thanks, Dr. Gangwani, for the nice introduction. Since this is a symptom which needs to be treated in all the conditions, that is why this is being discussed as such as a subject here. We used to call something as pruritus of unknown etiology earlier, but that's a terminology which should no longer be used because sometimes we know the etiology, but we still don't know the pathomechanism. So the preferred term is pruritus of undetermined origin, or PUO. The guidelines, I'll be extensively quoting from the guidelines, the European guidelines, which were developed by the European Allergy Forum and the European Association of Dermatology. These guidelines were published in 2012. And they have simplified quite a few things in this. So the guidelines, they address the patients of chronic pruritus presenting with different, including the unknown origin. If the cause is detected, then the disease-specific guidelines should be consulted. Now, a word about itch and pruritus. Itch arises when an evident alteration is present in the skin, which may or may not be locally produced. Thus, the cause could be local or systemic, and the sensation lasts for a few minutes to an hour, to a few hours. But pruritus is generalized idiopathic itching, most of the times idiopathic, sometimes you are able to find the cause also, which occurs usually in the absence of primary skin lesions. Many may affect large areas lasting for longer periods, sometimes months or years. It's often primary manifestation of systemic diseases. That means the pruritus may appear first and the systemic disease may be diagnosed at a later date. Pruritus as such is a symptom of many skin diseases, and it can cause significant loss of quality of life in these patients. It can occur in acute form or chronic form, as I have mentioned, and still, despite all the decades of research and treatments, we still have a lot of need which is unmet. So, itch-scratch cycle we all know. Now, talking of the classification of the itch, this is 2003 classification in which they had mentioned 4 types of itch. One, that is the pruritoceptive, which is originating from the skin due to inflammation in the skin or due to the damage in the skin. Say, for example, xerosis, urticaria, scabies, insect bites, etc. Then the second one is the neuropathic itch, which is due to the pathology located at any point along the afferent pathway. That can be in the form of branchioradial itch or the notalgia. And then you have a neurogenic itch, which originates centrally, but there is no evidence of a neural pathology. For example, even cholestasis through the action on the opioid receptors can mediate itch. And finally, the psychogenic, for example, parasitophobia and compulsive disorders. Then another alternate classification was given, that was in 2005, which seems to be more simple. One is the dermatologic itch, then the neurologic itch, the systemic itch because of systemic diseases, and then somatoform or the psychogenic itch, and then there were mixed varieties or some other rare conditions. So this classification was easier to understand and easier to remember and was more helpful in evaluating the individual patients. Now, the present classification of chronic pruritus, that is by IFSI, it differentiates between the pruritus on the disease-inflamed or the inflamed skin and the pruritus on the normal skin and the pruritus with the chronic secondary skin scratch lesions, basically. Epidemiologically, pruritus is, there are no very well controlled studies, especially in our country there are no studies. Most of the studies are European, and it's a common problem. About 60% of the elderly, they suffer from pruritus. 8 to 9% of the general population is suffering from pruritus, and the lifetime prevalence is expected to be about 22%. Now, when they were trying to revise the guidelines for the management of chronic pruritus, there were a lot of problems because the studies cannot be uniform as the causality is so much different in different patients. So it becomes so much difficult to frame a particular kind of study and have uniformity in all these studies to be able to develop the guidelines. So the guidelines have been developed after all the factors taken together with all the perseverance, whatever methodology has been used. Now, talking of the dermatological disorders which can induce pruritus, there can be localized itch and there can be a localized itch with rash. So localized itch with rash, the examples are psoriasis, seborrheic dermatitis. We know all these conditions, and the localized itch without rash is notalgia, meralgia paresthetica, branchioradial pruritus, post-stroke pruritus, phantom itch, brain tumor or abscess, multiple sclerosis, transverse myelitis, and diabetes mellitus. Some of these conditions are listed amongst the generalized itch causes as well, because if the disease is generalized, then it may lead to generalized itch, like for example psoriasis. So skin diseases we all know which are the primary diseases, and then we see all the lesions of these diseases. But then we need, for the sake of differential, we should remember that. Now, talking of the generalized itch without rash, this is perhaps the most important list which we should be looking at when the patient reports to us with chronic pruritus. Xerosis is the simplest of them. Then we have thyroid disease, even iron deficiency can cause chronic pruritus, renal failure, cholestasis, then lymphomas, leukemias, multiple myeloma, paraproteinemia, polycythemia vera, carcinoid tumor, other solid tumors, HIV, hepatitis C, which is relatively less common, Sjogren's syndrome, dermatomyositis, drug hypersensitivities, then aquagenic pruritus in the elderly, then fiberglass dermatitis, neurodermatitis, and anorexia nervosa. Now, when we look at the systemic causes of pruritus, we can classify it in this way, that we can talk about the metabolic or the endocrine group, then we are talking about the hepatic, renal, then hemopoietic diseases, then the allergic disorders, the drugs, neurological, psychoneurosis, various malignancies which I talked about, and miscellaneous diseases like SLE, HIV, sarcoid, and Sjogren's syndrome, etc. Now, practically any drug can cause pruritus, but this is the list of the common drugs which can cause pruritus. Now, these agents are actually in the alphabetical order mostly, but if you see the AC inhibitors, antiarrhythmic drugs, antibiotics, and NSAIDs, antidepressants, antidiabetic drugs, antihypertensive. See, these are the drugs which most of the elderly patients, the senior patients are on. So it becomes so much difficult sometimes to find a drug, because it becomes difficult to stop so many drugs in a particular patient. So how to approach a patient of chronic pruritus? If the patient has primary skin lesions, then we have to look at the dermatological cause. We have the list earlier given. And then if there are no lesions, then the non-dermatological causes you have to look for different, and then this is the basic investigation list, that is the CBC and creatinine level, the liver function test, the thyroid function test, HIV status, chest X-ray, and of course the drug history. So in the history, what are we looking at? We are looking at the onset of itch, how old is the itch, how severe is the itch, what time is the itch more, whether it is the daytime or the night time, what are the relieving factors of itch, what are the aggravating factors of itch, whether the bathing improves the itching or increases the itching, and various skin care methods improve the itching or cause the itching. Then previous treatments, whatever treatments the patient has taken. Then the other contacts, like for example, there are family members, they may be having itchy disease, the patient may be having a pet at home, there may be a history of recent travels abroad and may have acquired some infection from there, and then previous history of itch in the past if the patient had similar kind of episodes. and other past medical history, history of other disorders, then social history, family history, and review of other systems when we have no other clues. So I mentioned part of the test there. This is a little more complete list, and it goes on to add the serum iron and ferritin level, and if the patient is more than 40 years old, then stool occult blood examination as well. Now, if this is not enough, we can't find anything out of these investigations, then the next line of investigations can be undertaken: the hepatitis serology, the parathermone, the immunoelectrophoresis, for the investigations for EPP, then biopsy. Biopsy, if we are suspecting a vesiculobullous disorder, then we should be doing a direct immunofluorescence as well. Then swab for candida, especially the vulvovaginal areas involved, mucocutaneous involvement by the itch. And then in the urine, you have you have to look for the mast cell metabolites, and further imaging studies and bone marrow examination to rule out the myeloproliferative disorder. So these are the general avoidance techniques, like using moisturizers, avoiding hot water showers, and etc., etc. Now, coming to the therapy, the causative therapy based on the etiology would be the cornerstone of any patient who is suffering from the chronic pruritus. So if you have allergen, avoid the allergen. If you have a drug responsible, discontinue. And in certain patients, even surgical treatments have been advised, which can be so bad sometimes. So whatever we decide, it should depend upon whatever is the level of evidence, what is the safety of the drug, what the drug interactions are, depending upon the age of the individual, other disorders the patient is suffering from. So this is the stepwise approach for the management of chronic pruritus. So general therapeutic measures: systemic antihistamines, topical corticosteroids. The step 2 is systemic causative adaptive therapy if the mechanism of or origin is unknown, that is the renal or hepatic. And then in the step 3, the pruritus of unknown origin or refractory cases. To step 2, symptomatic topical or systemic therapy, capsaicin, calcineurin inhibitors, cannabinoid agonists, and naltrexone, gabapentin, UV phototherapy, and immunosuppressive agents. And then concomitant therapy in every step when we are trying to find the cause of the disease, and besides the general therapeutic measures. And if the patient is psychologically very distressed, then psychosomatic care as well, and we have to look at the scratches, we have to avoid them, we have to treat them. So antihistamines we all know. Now beyond that, these are the other agents which are used. I will not name all of them because of the paucity of time, but then we are or all have been using most of them actually. The anti-serotogenic or IL-2 blockers topically, and anti-leukotrienes, which don't have too much of evidence. Now topical agents, capsaicin is very popularly discussed in the Western world, but in my use I have not been able to find it very useful. The problem with capsaicin is when you start using it, it initially causes pain in the skin, which may last for 2 weeks, and then finally the antipruritic action may start. So phototherapy we all know, NB-UVB, broadband UVB, UVA therapy, and the bath PUA all can be tried, but NB-UVB is by far found to be the most useful. Now the hepatic itch. In the hepatic itch, what is happening? There is a opioid neurotransmitter hypothesis. The plasma of patients with cholestasis and pruritus react with the opioid receptors in the brain, and they induce the opioid receptor mediated scratch. Possibly there is a range of opioidergic tone in the patient with cholestasis. A drug that reduces this tone, like for example naloxone, can alleviate pruritus. There is another hypothesis, that is the autotaxin hypothesis, in which the LPC has been converted into enzyme LPA through an enzyme, and increased LPA levels are specific for pruritus of cholestasis. Now what are the therapeutic options in cholestatic pruritus? These are the list. This is in the recommendations. And the naltrexone, naloxone, nalmefene, all these have been having RCTs to support their presence here in the list. Now, this ursodeoxycholic acid, basically this increases the excretion of hydrophobic bile salts. That is how it works. Rifampicin is also known to reduce the pruritus through the action on the cytochrome P450. Thalidomide, though mentioned here, but because of its toxicity, is rarely used, generally should be avoided. Now, this is a very interesting thing. The mu receptors, they induce itch, and the kappa receptors, they suppress itch. And the combination of treatments with the mu receptor antagonist and the kappa receptor agonist, that is butorphanol, is found to be useful in patients who had chronic pruritus. In fact, butorphanol is supposed to have both kind of actions in another study. So it can be used alone as well. Invasive procedures: charcoal hemoperfusion, plasmapheresis, partial extrusion diversion of bile, ileal diversion, liver transplant. Even liver transplant has been considered to treat the chronic pruritus because of the liver failure. So one can see how much trouble these patients are, that they get priority because of the pruritus as the cause for the early liver transplant. Coming to the uremic pruritus. Now, in the uremic pruritus, UVB is basically modulates the Th1 and Th2 lymphocytes differentiation and attenuates the Th1 expression. So that is how it improves the uremic pruritus. Besides this, the other drugs which are used are like tacrolimus topically, oral thalidomide, which I mentioned earlier, even cyclosporin. See, cyclosporin, the patients who are receiving cyclosporin, the renal transplant patient, they don't get uremic pruritus. So even cyclosporin can be used to get rid of the uremic pruritus. Now, direct metabolic factors, that is the increased concentration of divalent ions like calcium and magnesium, is also given as a hypothesis for the uremic pruritus. Increased level of parathyroid hormone are also given as the reasons for the uremic pruritus. Besides, we have increased in used topical steroids, aqueous creams we all use in all the chronic renal failure patients, and then parathyroidectomy has also been suggested as a treatment. Doxepin is used as a single dose HS from 10 to 75 milligram, and but then the dose has to be increased slowly. In elderly patients, there is a lot of chance of side effects like glaucoma, urinary retention, interactions with the other drugs. So generally not used for this reason. So these are the future drugs for which are under trial or are being developed to treat the chronic pruritus. So how you manage a patient with the chronic pruritus? A patient lands up with you, and the patient has some pathologic lesions. You look at the lesions, you diagnose the disease, and then if required you take a biopsy or do a DIF and treat accordingly. And if there is no lesion, then the lesions may be present on the itch areas. So if the lesions are present on the itch areas, the chronic lesions may lead you to diagnosis of lichen simplex or prurigo nodularis. Treat accordingly, manage at the psychiatric plane also, and if none of this is there, and then you follow this particular pathway. So key summary points are: sedative antihistamines are the first choice therapy in chronic pruritus, even though I don't agree with this thing that all the time we should be using the sedating antihistamines only. The UV phototherapy is recommended for the generalized pruritus. Anticonvulsants like gabapentin and pregabalin and the pain modulators are recommended in the neuropathic pruritus. Antidepressants are recommended in the form of chronic pruritus not responding to other therapies, and the systemic glucocorticoids very rarely can be given for up to 2 weeks time in a desperate situation. Serotonin reuptake antagonists and thalidomide are not recommended because of the side effect profile. So this is how we manage the impossible itch. But then remember, we don't combine these two agents when we are going up the ladder there. So that's my last slide. Thank you for your attention.